Planning my treatment options for patients with polycythemia vera. I first consider their risk and their disease burden. How likely are they to have blood clots or bleeding? And then what is their burden as it relates to that risk as well as symptoms and splenomegaly? First, I view that all patients benefit from control of the hematocrit. I think that part is very clear. With a hematocrit of clearly under 45%, pretty much at all times for all patients with polycythemia vera. There are individual patients which may benefit from that being a little lower, perhaps in women, perhaps in people in which that's inadequate for their symptoms. The limitations of phlebotomy are it can be hard on the veins, it can lead to iron deficiency, it might exacerbate some of the disease-associated symptoms. So sometimes that's where medical therapy in that control comes into play, but hematocrit under 45 at all times for all P vera patients after diagnosis. Second, aspirin. There have been randomized studies which clearly show that a low-dose baby aspirin is helpful in patients with PV, particularly high-risk PV. Given that aspirin is a fairly benign therapy, we largely recommend low-dose aspirin, 81 milligrams or 100 milligrams in Europe for all patients with PV. Limitations just being if you're aspirin allergic or are already on warfarin or other blood thinners, it may exacerbate the risk of bleeding. If somebody's already on other antiplatelet therapy, we may be able to just leave them on clopidogrel or what other therapy that they were on. Now, in many individuals, the limitation of both of these therapies, phlebotomy and aspirin, is that they don't fully control all of those aspects of the burden of the disease. Our current guidelines for a response in P vera is control of symptoms, control of splenomegaly, and having the blood counts adequately controlled. The white cells, the platelets, and the red cells. So for patients on phlebotomy and aspirin, it may help the symptoms some, it may help the red cells, but it's not going to do anything for the white cells, the platelets, the spleen, and sometimes multiple of their symptoms. I believe that the majority of patients with PV benefit from cytoreductive therapy. And our current frontline cytoreductive therapy is either hydroxyurea or interferon according to our current NCCN guidelines. Hydroxyurea is a pill. It is simple to take for most. Its downside is that it's a nonspecific therapy. It can lead to neutropenia or thrombocytopenia. It frequently is just not active enough against symptoms, splenomegaly, or other difficulties that people can have. It can increase the risk of cutaneous malignancies, and controversially, it may have a slight impact on increasing the long-term risk of acute leukemia. That's difficult to prove, but it's also very difficult to disprove. I find that hydroxyurea, where it lets us down, is really in the limitation of its activity. It's a very non-specific therapy, best used for controlling the counts, but frequently leaves us disappointed with other potential goals. Interferon, or the long-acting interferons, and now the ropegylated interferon alpha-2b in Europe, is a additional frontline therapy. It is an injectable agent. It is a biologic agent administered once to twice a week. It can help to lower the counts. It may help to improve symptoms, particularly if they're related to the counts. Its impact on splenomegaly is probably less. Indeed, the European indication is for P vera patients who don't have splenomegaly. Its impact on significant symptoms is probably more modest. Between hydroxyurea and interferon, there is a hope more than being truly proven beyond a shadow of a doubt at this moment, that it may have a greater impact on delaying disease progression. Now, in many individuals, this frontline therapy will be inadequate, and those that fail hydroxyurea in particular, we have ruxolitinib approved as a therapy. a JAK1 and JAK2 inhibitor that is particularly helpful for helping to control the hematocrit for individuals that are continuing to have difficulty, need for phlebotomies, have become intolerant for phlebotomy, have progressive splenomegaly, have difficult symptoms, have been resistant or intolerant to hydroxyurea. That medication as well is an oral medication. It's a pill. Its limitations are not many, but its limitations, its benefits are it has perhaps the greatest activity against splenomegaly and symptoms of any of the P-vera medications. Its toxicities that we monitor for are a increased risk of herpes shingles, the potential of lowering the blood counts, as well as perhaps a slightly higher risk of non-melanoma skin cancers.